طلبتنا الأعزاء السلام عليكم. Today this lecture will be the second lecture in the reproductive system. It will be about the biochemistry of the female reproductive system. At the end of this lecture, certain things must be memorized by the student, which are the hormones that regulate the function of the female reproductive system, and the type of these hormones, where they are synthesized, and how are they metabolized and transported in the circulation. In addition, the regulatory mechanism that control the female reproductive system must be stated, and the function of each individual hormone. In addition, lastly, we summarize how can the hormone used as a marker to assess the female reproductive health. How can we use by lab test, how can we use all these individual hormones to assess the health state of the female reproductive system. According to the site of production or synthesis of the female reproductive hormone, we can classify this hormone into hypothalamic hormone that are synthesized from the hypothalamus, and the pituitary hormone that are produced in the pituitary gland, and we have the gonadal hormone, which are the ovarian hormone. The first thing are the hypothalamic hormone, and we have mainly two types. We have the gonadotropin releasing hormone, which stimulate the production of the pituitary hormone, the follicle stimulating hormone, and the luteinizing hormone. So the first hypothalamic hormone is the gonadotropin releasing hormone. The other one is the dopamine. Dopamine mainly control the prolactin secretion from the pituitary gland, and the effect of dopamine is inhibitory, while the gonadotropin releasing hormone are stimulatory. It stimulates the production of the gonadotropin from the pituitary gland, which are the follicle stimulating hormone and the luteinizing hormone. The other set of hormone are the anterior pituitary hormone. We have what is called the gonadotropin, the luteinizing hormone, and the follicle stimulating hormone. Because the secretion of the hypothalamic gonadotropin releasing hormone is pulsatile, it is not constant throughout the day, so the secretion of both the luteinizing hormone and the FSH, the follicle stimulating hormone, is also pulsatile, and these pulses may occur over the day or over the monthly cycle. In addition, the secretion of these two gonadotropin, the luteinizing and gonadotropin, are not parallel. It means that they not increase at the same time or decrease in the same time. Sometimes the LH in certain period of the cycle may be increased while the FSH is low, and sometimes for example in the beginning of the cycle the FSH may be increased. So they are not parallel. Each one have its own pathway, and this depends on the gonadotropin releasing hormone, in addition to the feedback from the ovarian hormone. The follicle stimulating hormone stimulates the ovarian follicle, causing an ovum to grow. It also triggers the production of estrogen in the follicle. When estrogen increases, this will tell the pituitary gland to stop producing the follicle stimulating hormone, and it will start to making more luteinizing hormone. This shift from the FSH to LH causes the egg to be released from the ovary, and the process is called ovulation. I'm sure you have one lecture about the menstrual cycle and the change in the level of the FSH, LH, and different type of the cycle by the Department of the Physiology. So it is better to read them together with this lecture. The luteinizing hormone usually stimulates hormone production, while the follicle stimulating hormone stimulates the production of the or the development of the ovarian follicle, the germ cells development, similar to what we talk about in the male reproductive system. We say that the LH stimulates testosterone production, while FSH in the male stimulates the spermatogenesis. The hypothalamic hormone and the anterior pituitary hormone are all peptide in nature. The another anterior pituitary hormone is the prolactin. It is secreted by the acidophilic cell in the pituitary gland, and mainly it is important during pregnancy and in the lactation in the postpartum period. It will stimulate and induce the production of the milk. The control of prolactin secretion is usually inhibitory by the dopamine from the hypothalamus. So if there is any defect that prevent dopamine from reaching to the prolactin secreting cell, then there will be hyperprolactinemia. The effect of the hypothalamus on the pituitary regarding prolactin is inhibitory rather than stimulatory. So anything that, for example, if we have any cut in the a tract that connect the hypothalamus to the pituitary, then for example by tumor, by infarction, there will be hyperprolactinemia, or any medication that have an anti-dopaminergic effect the patient will have hyperprolactinemia. So it is very important to ask for these medication in history taking if you suspect that any patient have hyperprolactinemia and galactoria. It is very important hormone, not only for the induction or production of milk production, but also it inhibits, if there is hyperprolactinemia, it will inhibit the FSH and LH production. So it is very important to check for all these things. The ovarian hormone are steroid in nature, they are not peptide, and we have three main types. We have the estrogens. The estrogens are many types also. We have the estradiol, which is the most active one, and we have the estrone and the estriol, which is the inactive estrogen, and all the estrogen eventually will be converted to the inactive one, the estriol. But the most important we must put in mind is the estradiol, and because it is synthesized mainly by the ovary specifically, so we can use it as a marker of ovarian health. Estrogen have many action in addition to its main function as a main hormone in the female reproductive system. It is responsible for the development of the female secondary sex character, and in the development of the breast and uterine growth. It is important for the menstrual cycle regulation, and together with progesterone. In addition to all these specific action of estrogen, it also have a metabolic effect on the body. It is very important for calcium homeostasis. Presence of estrogen in good quantity, in a normal quantity, will prevent bone resorption. While after menopause, when the estrogen level will decrease, we will find that the prevalence of osteoporosis will increase. So it has a protective effect on the female bone. And in addition, in the pubertic age, it accelerates the bone growth. So it is very important for the normal bone growth, and it have an effect on the lipid profile. So it will enhance the production of the good lipoprotein, the high density lipoprotein. So patient before the menopause, or generally not patient, sorry, the person before, the female before the menopause, have a protective effect against the cardiovascular disease, and this is maintained by the normal level of estrogen, which will lead to increase the level of the good cholesterol, which is the high density lipoprotein. After menopause, we will find that the risk of cardiovascular disease will be similar between male and female, because estrogen will decrease. Other metabolic effect of estrogen is its effect on the binding protein. Many compounds in the body cannot circulate freely, so they need to be bound to certain protein. These binding protein, we have the, for example, the cortisol binding protein, the thyroxine binding globulin, and we have the sex hormone binding globulin, and certain protein that bound certain mineral. For example, the iron and copper need a certain protein. The copper require the ceruloplasmin. The iron will be transported by transferrin and stored by ferritin. The estrogen will increase the level and affect generally the level of the plasma protein. So in interpretation of the result of this analyte, we will take in take in consideration that the estrogen, if it is in excess, so we need another reference range. For example, a patient taking contraceptive pill will have a level of estrogen that is higher than other female that are not taking the contraceptive pill. Also, this occurs during pregnancy. Progesterone is the another ovarian hormone. It is a steroid hormone, and it have two sites for the secretion. If the patient was pregnant, then it will be secreted from the placenta, but in non-pregnant female, it is secreted from the corpus luteum, and usually the concentration and secretion occur during the second half of the cycle, which is called the luteal phase. The main function of progesterone is to prepare the endometrium to the getting and receive the fertilized ovum, and it is important to maintain the early pregnancy by maintaining the environment in the uterus. Other metabolic effect of progesterone is that it can increase the basal body temperature by about 0.5 Fahrenheit, and it is one of the marker that can be used to detect that ovulation occurs. If the temperature increase, it indicates that in the second half of the cycle, it may give a hint that ovulation may occur. Other ovarian hormone are the androgens, which are C19 steroids. They are converted to estrogens by the process of aromatization using the enzyme aromatase. And we have two main androgens in the female. The testosterone is secreted in small quantity directly from the ovary, and the concentration of testosterone is about 1 to 10 its concentration in the male. يعني تركيز التستوستيرون بالفيميل يعادل 1 إلى 10 من تركيزه in the male. The other androgen is the androstenedione, هو المين androgen, and it can be converted to other estrogen, to estrone, or converted to testosterone in the extraovarian tissue. فممكن androstenedione يتحول إلى testosterone، وممكن التستوستيرون directly secreted from the ovary, but usually the direct secreted testosterone is in a small quantity. The ovary synthesize estrogen, progesterone, and androgens. The ovary usually have the same steroigenic pathway that are followed in other organ that produce steroid. For example, in the adrenal cortex, which produce androgen, glucocorticoid, and mineralocorticoid. So the steroigenic pathway is the same, started from cholesterol, pregnenolone, and as we will see in the next slide, the difference between the steroigenic pathway and the biosynthesis of these ovarian hormones that occur in the ovary the difference between this organ and the steroigenic pathway in other organ, for example the adrenal cortex, is that first of all, the aromatase system is very active in the ovary. This aromatase system is very important for converting the androgens to estrogens. The second important difference is absence of certain enzymes that are important in the conversion of the cholesterol and other metabolite to a glucocorticoid like cortisol, and mineralocorticoid like aldosterone. These enzymes, for example, the 21-hydroxylase is absent in the ovary, and the 11-beta hydroxylase is also absent in the ovary. So the ovary cannot produce glucocorticoid or mineralocorticoid. This is the difference between the steroidogenic pathway in the ovary from the steroidogenic pathway in other organ, for example, the cortex, adrenal cortex. The type of steroids that are produced are the estrogen, progesterone, and androgens. No glucocorticoid or mineralocorticoid. The aromatase is very active. It can convert the androgens in the ovary to estrogens. This is the steroidogenic pathway, starting from cholesterol, converted to pregnenolone, then to this metabolite, 17-hydroxypregnenolone, then to dihydroepiandrostenedione, then androstenedione and testosterone will be interconverted by a reversible reaction. Finally, estrone, and the most important and active estrogen is the estradiol, and this is the estradiol. This is the only pathway that occur in the ovary, while this pathway can occur in the adrenal gland, adrenal cortex, and end by the formation of the mineralocorticoid and the like the aldosterone and the glucocorticoid, the cortisol. This doesn't happen in the ovary. Only these steps occurs in the ovary. We have about 20 types of estrogen. The most important is the estradiol, E2, and the estriol, the E3. The most important is the estradiol, and because it is synthesized by the ovary and almost exclusively by the ovary, estradiol can be measured as a marker of ovarian function. It is a marker of the ovarian function. How does estrogen transported in the blood? Since estrogen is a steroid hormone, so it is water insoluble and need to be transported by protein. So that about 97% of the estradiol is bound to plasma protein, while 2 to 3% are the free form. The binding protein could be either specific, which is called the sex hormone binding globulin, or which is characterized by binding to estrogen with high affinity, يعني binding يكون strong, but it have a low capacity. While the other protein is the albumin. Usually the binding is with low affinity, weak binding, but with high capacity. And because the binding of estrogen with albumin is with low affinity binding, weak binding, so that we considered the estrogen that's bound to albumin as the biologically available together with the free. So both the free estrogen and the albumin bound albumin is both considered, both of them, as the biologically available, so they can be easily detached and can be later on considered for use. Sex hormone binding globulin is more in female than in male, not the estrogen. The sex hormone binding globulin concentration is more in the female. Why? Because it is increased already by estrogen. Other factors that may increase the level of estrogen are pregnancy, because of the high level of estrogen. The oral contraceptive pills that contain high level of estrogen also can increase the level of the sex hormone binding globulin, and case of hyperthyroidism characterized by having a high concentration of the sex hormone binding globulin. While other conditions, for example the obesity, hypothyroidism, and androgen excess, characterized by low level of sex hormone binding globulin. What is the clinical significance of knowing these facts is that we must put this fact in our mind when we do interpretation of the level of estrogen in obese or in hypothyroid patient or androgen excess, or in case of pregnancy or oral contraceptive pills. These all may affect the level and affect the overall concentration of the estrogen. So these are very important in the interpretation. How does estrogen metabolized? the main estrogen that is active, which is the estradiol, is converted to estrone. Then the estrone have two pathways. Either it is conjugated with glucuronic acid, so it became water soluble and can be removed in the urine by the kidney, or the estrone undergo more reaction. The aim of this reaction to inactivate it. This reaction may be hydroxylation at certain part of the molecule of estrone, or maybe oxidation, reduction, methylation. All these are examples of the chemical reaction that may occur on the estrogen molecule, the estrone, that will inactivate it. Or the other pathway, as we said, it can be conjugated with the glucuronic acid to become water soluble and then excreted in the urine. The progesterone is another sex hormone, steroid hormone synthesized by the ovary, and it follows the same pathway as in the adrenal cortex. We have the same estrogenic pathway starting from cholesterol, as was shown in the previous scheme, and can be synthesized from cholesterol or from low density lipoprotein. And there is no specific binding protein for progesterone. It can bind either to corticosteroid binding globulin or other protein. So there is no specific binding protein for progesterone, and about 2 to 10% are free progesterone in the circulation. It's more than that of the estrogen. The percentage is 2 to 10%. How the progesterone is inactivated? Either by reduction reaction or by conjugation, for example with glucuronic acid or any other molecule that can be that is conjugated with progesterone to make it water soluble and excreted in the urine. We have many classes of the progesterone. They may be pregnenolone, pregnenolone, or pregnenolone. These metabolites later on will bind with the glucuronic acid and excreted in the urine. So this is the metabolism of progesterone. The disturbance in the gonadal function in the female may be presented either as amenorrhea, which is either primary or secondary amenorrhea, or it may be presented as infertility, which may be primary infertility in a couple who have never had a successful pregnancy, or secondary infertility that occur in a couple who have previously a successful pregnancy, or it may be presented as hirsutism and virilization. The abnormality, depending on the site of the defect, is either in the gonad itself, in the ovary, or in the higher center, which is represented by the pituitary or the hypothalamus. If the defect is in the ovary itself, we call it a hypergonadotropic hypogonadism. In both cases, whether the defect is in the hypergonadotropic or hypogonadotropic hypogonadism, in both cases we have hypogonadism. But the difference between the two situation is the site of the defect. If the defect is in the ovary itself, then we call it hypergonadotropic hypogonadism, and the cause for this naming is because the gonadotropin as a feedback response will be increased. So the output from the ovary will be low and the gonadotropin will be increased. This in case of defect in the pituitary or in the hypothalamus. While in hypogonadotropic hypogonadism, also the output of the ovary will be low, whether they are hormone or in the oocyte quality, and the cause in this condition is in the hypothalamus or the pituitary gland, so that the gonadotropin are low and the output from the ovary is also low. In hypergonadotropic hypogonadism, the level of estradiol will be very low, and as a feedback response, the level of the FSH, the follicle stimulating hormone, which is a gonadotropin from the pituitary, will be increased. While in case of hypogonadotropic hypogonadism, the estradiol level also will be low, which is the outcome from the ovary, while the serum gonadotropin level, the luteinizing hormone and the follicle stimulating hormone, are also low. So in case of hypogonadotropic hypogonadism, the pituitary hormone and the ovarian hormone are low, and the cause is in the pituitary. Due to low stimulation, the ovary output also will be low. Amenorrhea is the absence of menstruation. Many causes are behind this condition. Some of the causes is due to hormonal abnormality. It could be primary or secondary. What is the difference between the primary amenorrhea and the secondary? Primary amenorrhea is the no menstruation, spontaneous periodic menstruation by the age of 16, regardless whether the female had her secondary sex character or not. So if there is no menstruation by the age of 16, which is spontaneous and periodic, then this is called primary amenorrhea. Most of the cases are due to chromosomal abnormality. How can we use the hormonal assay to investigate this condition? We test for the gonadotropin, serum gonadotropin, which are the level of the follicle stimulating hormone and the level of the luteinizing hormone. If the level of these hormones are higher than normal, this indicates that the defect is in the ovary itself, and as a compensatory and by the feedback mechanism, the gonadotropin increase to trying to stimulate the ovary. And if the defect in this condition is hypergonadotropic hypogonadism and the defect is in the ovary, it is preferable to do chromosomal analysis. But if we check the level of the gonadotropin and they were low, then the defect is in the higher center, so it's either from the pituitary or the hypothalamus, and in this condition we must check the other hormone from the pituitary, and radiography and imaging study is also helpful. While the difference between the primary and secondary amenorrhea is that the primary didn't have any menstruation, which is spontaneous and periodic by the age of 16, while the secondary, she has previous normal menses, but then it was absent for 6 months if you have normal menstruation before this period, or the menses will be absent for 12 months if she has already oligomenorrhea. So the secondary amenorrhea, it means that the female have previously normal menstrual cycle, but it has been absent for 6 months in case her previous menses was normal, or it's absent for 12 months if she has previously irregular oligomenoric pattern. The most common cause of secondary amenorrhea is pregnancy and lactation, and this can be assessed by measuring the hormone beta HCG in the urine or in the blood. So we can use hormonal analysis to exclude the first and the most common cause of secondary amenorrhea, which is pregnancy and lactation. Other cause could be the hypothalamic disorder, and in this condition the defect is in the gonadotropin releasing hormone and result in hypogonadotropic hypogonadism. Other cause of secondary amenorrhea is a pituitary disorder, any disease that affects the pituitary cell that produce the gonadotropin, for example the follicle stimulating hormone producing cell or luteinizing hormone producing cell, for example by a tumor that destroy the cell, or by, for example, radiation, or any disease that cause destruction to the area, then in this may lead to secondary amenorrhea, and the defect is hypogonadotropic hypogonadism. Sometimes ovarian disorder, in this condition the cause is hypergonadotropic hypogonadism, and the patient, for example, either have premature ovarian failure, which is the failure of the ovary to perform well before the menopause, we call it premature ovarian failure, or sometimes the ovarian disorder in case of polycystic ovarian syndrome is a cause of secondary amenorrhea, and we will talk later on how can we use the hormonal analysis to diagnose the polycystic ovarian syndrome. The thyroid disorder, whether hypo or hyperthyroidism, also may be a cause of secondary amenorrhea, and this can be easily assessed by measuring the level of thyroid stimulating hormone. It must be one of the important steps in diagnosis of secondary amenorrhea. Other cause of secondary amenorrhea may be adrenal disorder, for example, Cushing syndrome or Addison disease, or could be any disease of the adrenal gland, maybe tumor or hyperplasia, whatever the cause that cause, whatever the defect that cause decrease in the production or increase or decrease in the adrenal hormone, it also may lead to secondary amenorrhea. All these defects can be assessed by measuring the hormonal level. For example, pregnancy can be excluded by measuring the level of the serum or urine beta HCG, hypothalamic by can we measure it, and pituitary by measuring the level of the gonadotropins. The ovarian disorder, for example, the premature ovarian failure and polycystic ovarian syndrome, can also be assessed by measuring the level of the follicle stimulating hormone, luteinizing hormone, the ratio between them. We can perform the androgen level. All these can assess in the diagnosis of the polycystic ovarian syndrome. Thyroid disorder can be excluded by measuring the level of the thyroid stimulating hormone. Adrenal disorder also we can screen for Cushing syndrome, for example, by the 24-hour cortisol in the urine, or by the measurement of the dexamethasone suppression test, and so on. And we must always remember that pregnancy is the most common cause of secondary amenorrhea. This logarithm is an example of how to investigate for primary amenorrhea by using for example, the hormonal level. If the patient presented with primary amenorrhea, then first we will exclude prolactin because it is a cause of hormonal disturbance and affect the level of FSH or LH and cause inhibition of them. And also we can check the thyroid level. These are simple and can be checked at the beginning. Then we look for if the patient have secondary sexual character. If they are not present, then we check for the level of gonadotropin, the follicle stimulating hormone, which is gonadotropin released from the pituitary. So if the level of the FSH was low, it means that the defect is in the pituitary and the patient have hypogonadotropic hypogonadism. While if the FSH is high, then the problem is in the ovary and the level of the gonadotropin is normal or high. This is called hypergonadotropic hypogonadism. So the problem is in the ovary. In this case, we proceed to do the karyotyping, maybe a chromosomal defect. If the secondary sexual character are present, in this case, then we look for another approach. For ultrasound, we can see if the uterus is present and or not, and if it's present, it means that there may be outflow obstruction. If not present, then it may be also chromosomal defect, and we will proceed in this direction. The polycystic ovarian syndrome is one of the diseases that are very common, and we can use the hormonal analysis, biochemical analysis, as an aid in the diagnosis. It is thought to be a hypothalamic disorder. The defect is in the hypothalamus. The patient either presented with infertility, hirsutism, obesity, menstrual disturbance, maybe amenorrhea or irregular menstrual bleeding, oligomenorrhea. All these may be the presentation. It is a very common disease. The main characteristic is that the androgen is high, and there is chronic ovulation, no ovulation, and there is normal adrenal function, normal pituitary function. So it's hypothalamic disorder with a normal pituitary action and no adrenal disease, and there is hyperandrogen level plus a chronic ovulation. How can we use the lab test to investigate and assist in the diagnosis of polycystic ovarian syndrome? We can measure the level of the testosterone and the dihydroepiandrosterone sulfate. the luteinizing hormone, follicle stimulating hormone. All these can be useful in the diagnosis of this common syndrome. Usually the luteinizing hormone is elevated, the follicle stimulating hormone is low, and if the ratio of the luteinizing hormone to the follicle stimulating is more than 2.5, this indicates the presence of this disease. Why we measure the total testosterone? As we said, it is hyperandrogenism is present in this disease, and the total serum testosterone is elevated in most of the patients. And even if the serum testosterone, the total is normal, then the free is usually elevated. In this disease, the estrogen is high. Why? Because there is hyperandrogenism in this disease, and because in the female the aromatase system is very active, so the excess androgen all will be converted to estrogen, and this continuous estrogen exposure will lead to chronic anovulation. Another example of how can we use the hormone to hormonal analysis to evaluate the certain condition is when we want to detect if the ovulation function is normal or not. And if we want to detect the ovulation, then we can measure the level of progesterone, and in addition we can measure the LH surge. Serum progesterone, if it is measured at day 21 to 23, starting from the first day of the cycle, and it was normal or at least more than 10 nanogram per ml, this indicates that the female have a normal ovulation, because after the ovulation the serum progesterone start to increase and peak within 5 to 8 days after the ovulation, exactly in the mid-luteal phase, if the patient have a normal menstrual cycle or regular menstrual cycle. So the first indicator or hormone or biomarker that can be used to assess ovulation is measurement of serum progesterone in the mid-luteal phase, in the second half of the cycle, in the mid of this phase, at day 21 or 23 of the cycle. If the patient have regular menstrual cycle, if the level was normal, more than 10 nanogram per ml, this indicates that the female have a normal ovulation. Sometimes we measure the serum progesterone and it will be low, and if we want to interpret the causes of low concentration of progesterone, then it's either we can put a differential diagnosis, either there is anovulation, no ovulation has occurred, so that the progesterone didn't increase, or sometimes the luteal phase didn't produce enough progesterone. This is the second cause of low progesterone in this period. Or sometimes there is inappropriate time of sample collection. Sometimes the female take the blood sample at the beginning of the cycle, for example day 2, 5, 6, and it will normally be low, instead of the exact time, which is important to be correct and accurate, which is the day 21 or 23 of the menstrual cycle. So if she take it out of this date, out of the 21, it must be the sampling must be in day 21 to 23, otherwise it will give a false low concentration. The other things that can be helpful for assessing the ovulation is measurement of the luteinizing hormone surge. It can be measured 24 to 36 hours before ovulation, and if we found it is increased, then it will give us a clue that ovulation should occur, because it happened before ovulation, because the LH increased before ovulation. So if we measure it 24 to 36 hours before ovulation and we found that the LH is increased, this indicates that the ovulation will occur, but it doesn't make sure that ovulation had occurred. Another feature is that basal body temperature, it is not hormonal analysis, but it's one of the features of progesterone. Progesterone is a pyrogenic hormone, so if ovulation occurs, progesterone is produced in larger quantity, this will lead to a rise in the body temperature by about 0.5 Fahrenheit, and this will remain throughout the second half of the cycle, which is the luteal phase. How can we use the hormonal analysis to assess the ovarian reserve? One of the causes of infertility is a decline in the oocyte quality and number, the quality and quantity of the oocyte. This usually occurs in the female in their mid to late 30s and early 40s. So in this condition, we can measure certain hormone to give us an idea about whether the ovarian reserve is functioning good or no. We can measure the basal serum FSH and estradiol measurement. They are screening tests. If the FSH at the beginning of the cycle at day 3 is very high, this is associated with poor ovarian reserve and poor reproductive outcome. The other marker that can be used, or hormone that can be used in the assessment of the ovarian reserve, is the anti-Mullerian hormone. This hormone regulates the development of the follicle, the maturation of the follicle, and also assists in estradiol production. So if the level of the anti-Mullerian hormone is low, then it is associated with poor reproductive outcome and poor ovarian reserve. Inhibin B is another marker that can be used in conjugation with both the serum follicle stimulating hormone and estradiol to assess the ovarian function. Thank you.